Hey everyone, welcome to my show. It's 3 p.m. Eastern in DC, and I'm delighted to be here as I am every Friday talking about hot topics, things that I talk about with my primary care patients every day, like mental health, brain health, cognitive health, attention, and focus. That is going to be our topic of the day. We're going to talk about brains, arguably the most important organ in the body, the home of our every thought, every feeling, and every thought, of course, every feeling drives our behavior, right? So this is an important organ. Let's talk about it today. Patients come into me all the time worried about their risk for dementia. Understandably, dementia is a huge problem in our country. It is a huge problem for the patient, of course, causes a lot of morbidity and mortality. And dementia, of course, places a huge burden on the healthcare system, but also on families who are caring for loved ones. With an aging population and with dementia increasingly common, it's important we talk about the fact that we are not predetermined to develop dementia. Of course, there are exceptions. There are genetic predispositions to cognitive decline. But what's fascinating is the increasing amount of research that is out there showing that our brains are more plastic than we used to think. We used to think that our brains were like done being formed in our late teens, 20s. It turns out that our brains are plastic well into middle age and older age. And it turns out that we have more agency than we thought to help protect our brains, our cognitive health, our mental health, and our whole health. It turns out that caring for your brain is about caring for your whole person. So today, what I want to talk about is what I see in my office commonly. I want to talk about the sort of 6 pillars of cognitive health protection, how to protect your brain, and how to employ those features of brain health in a realistic, sustainable way. And then I want to answer any questions you might have. Um, right now, I have the settings turned on and I can't turn them off where only paid subscribers can ask me questions, but I really don't want that to be the case. I'd like for anybody to be able to ask me questions. So I'm working with Substack to figure out how to turn that off so everyone can ask questions. If you want to be a paid subscriber, fantastic. Support this work. That's amazing. I love it. Thank you so much. All the work I'm doing is just for my own pleasure because I love sharing information. But if you wanted to pay, that'd be great. But I want everybody to be able to ask questions. So if you're a paid subscriber and you happen to be able to ask questions, please ask. So let's talk about what I see commonly in my office. So here are 2 scenarios I see all the time. Number 1 is a patient in her middle age, maybe in her 50s, and she has a parent or 2 who has cognitive decline or dementia. And she comes in and she's exhausted from working and caring for teenage kids and managing her parents' health issues. And she's worried that she's going to develop dementia as well. So this patient in her middle age naturally is worried. I don't know a single person who wouldn't be worried about the risk for dementia when you have a family member with dementia. I mean, dementia is so uniquely traumatizing to the patient and to the family because, as you may or may not know, I mean, people tend to lose their loved one. They grieve the loss of their loved one before the actual end of their life. The decline in cognitive abilities and the loss of self is so distressing to the family and, of course, to the patient in many cases. So naturally, I have patients coming in concerned about their own risk. And then there's all this news online, all this information online to suggest that I, as a primary care doctor or doctors, could run a quick battery of tests and reassure you or not about your risk. Well, it turns out there is no single blood test for dementia. There's no single gene test for dementia. And the way we help patients, like my patient who comes in worried about her risk because her family members have dementia, is multifaceted. So in a patient like this, who's in her mid-50s, who's concerned about having dementia because a family member has dementia, here's what we talk about. I educate the patient first. I say, because this person is not symptomatic right now. This person does not have symptoms of dementia right now. She's just worried about her risk. At the same time, she'll tell me that she can't remember the names of people She met at a party 5 days later. She doesn't remember the name of that person. She can't remember the movie title, a movie she knows well. She tells me that she misplaces her car keys and her reading glasses. And those are good examples to bring up, of course, and I'm glad she's bringing these complaints up. But those are not necessarily symptoms of dementia. Those are commonly symptoms of inattention or stress or not having adequate sleep or just having a lot of open tabs in your brain. I always give this example to a patient I'm trying to reassure about the fact they don't have dementia, like this person. When I leave my office at the end of the day, at the end of the workday, and I go into my parking garage to get my car, I would say that 2 out of 5 times I go to get my car, I don't remember where my car is. And it's not because I have dementia. It's because I wasn't attending to where I was when I parked. I was on the phone, I was thinking about something else, and I know my parking garage well enough that I don't have to be, like, fully attending to it. So, that's an example of where if you don't attend to the detail in the first place, like you didn't make the memory to begin with, it's not gonna be there to retrieve it. So, there's a distinct difference between attention and attention deficit and not making the memory in the first place, and dementia, which is where the memory storage units are declining with time. So when a patient, let's go back to this patient. Patient is in her middle age. I wrote about this kind of person in my newsletter this morning, or it was my Q&A, or no, on Tuesday. I will explain that there are two basic buckets of dementia. There are two basic types. Obviously, there's a lot more nuance than what I'm going to go over here, but there are two basic types. There's the vascular type of dementia, and there's the sort of neurodegenerative types of dementia. And what's important for people to understand is that, again, in the spirit of empowering people with information and agency over their modifiable risk factors, it's important for people to understand that the vast majority of dementia in this country is because of vascular dementia. And the reason that's so important to understand is because vascular dementia has uniquely modifiable risk factors to it. The same risk factors that predispose people to heart attack and stroke predispose people to vascular dementia. That's bucket one, is vascular dementia. The other type of dementia is the neurodegenerative type of dementia. The Alzheimer's dementia, the Parkinson's type of dementia, the frontotemporal dementia, the other types of dementia that are degenerative neurologic. The first bucket I was talking about, the vascular type of dementia, happens on a very high level as a result of inadequate blood flow to the brain. So the brain is not being watered appropriately. That's bucket one, vascular dementia, for which there are many modifiable risk factors we will talk about today. The second bucket, the neurodegenerative bucket of dementia, has modifiable risk factors as well that we'll talk about, but is a different mechanism altogether. So the mechanism by which people develop dementia from Parkinson's, Alzheimer's, of course, depends on the disease we're talking about, but is an intrinsic brain problem, if you will. So the reason why I help people understand those broad brushstrokes is because then people can start to understand, A, that losing my car keys and not remembering where my glasses were or someone's name is not necessarily dementia, and B, how to frame the lifestyle modifications you might want to engage in order to prevent vascular dementia and neurodegenerative types of dementia. So again, this patient I'm talking to, it's a classic story. Patient in her middle age, she's going through menopause. She's got maybe young adult or teenage kids, and she's got a parent with dementia, and she's worried sick. The worry about dementia, the worry about anything, frankly, worry itself can mimic dementia. When we are worried, when we are stressed, when we are anxious, when we have multiple tabs open in our brain at one time, that alone can make people inattentive and or not remember things as readily. So a middle-aged person who has a lot going on might not remember where they put their reading glasses for that reason alone. Then there's sleeplessness. So when you're not sleeping well, whether it's because you're going through menopause or because you have a teenager in the house or because you drank too much alcohol or caffeine or whatever reason, that's not going to help your memory also. And then we can talk at the end if you want to. If someone has a question, I'm happy to answer this about hormone replacement therapy and cognition. A lot of controversy about this, but let's pin that for now. Let's pin that conversation about HRT and cognitive health if people have questions at the end. So I opened this by saying there are two classic patients who come in and talk about dementia. Number one is the person who has a family member who's in her middle aged, who's worried, who does not have symptoms other than maybe losing her car keys, which is not dementia, that's just inattention. And then there's the second patient who comes in who's actually has symptoms of cognitive decline. So a patient will come in, older patient generally, right, because dementia is age related, who comes in either with a family member or by him or herself with either reported problems with their memory or their family member is reporting it. And that's when we start to do some assessments for what I was just talking about, either vascular dementia or neurodegenerative types of dementia. And what people don't always understand is there isn't a single blood test. There isn't a single MRI. There isn't a single genetic test that can tell us with specificity in that moment what's going on. This is part of the problem with dementia care in this country. It is part of the problem, in addition to the fact that the healthcare system is broken, in addition to the fact that 100 million people in this country don't have a primary care doctor, in addition to the fact that patients with dementia don't always self-report, and there's stigma around it, and family members are trying to troubleshoot it because they don't always know what they're dealing with. And given the fact that the workup, the evaluation, the medical evaluation is very time consuming and requires patient participation, it requires patient willingness to have a whole lot of testing. This is why we're seeing a lot of undiagnosed dementia and why we're seeing a lot of dementia care not being properly administered. So we could talk about that forever, but I'll tell you what the general workup looks like for someone who I'm actually concerned about dementia. I'm not talking about the 52-year-old woman whose mom has dementia and she's losing her reading glasses. I'm talking about who warrants reassurance, of course, and a conversation about how to prevent dementia. I'm talking now about the person who comes in whose family member or themselves is reporting memory loss. And mind you, there are many, many patients who will come in and who I notice memory loss and they don't notice it and who are defensive about their cognition, whether they already know they have some cognitive loss or whether they don't know. The insight may be very low. The insight being low may be part of the cognitive loss. It may be part of the whole problem in general. So it's a very complicated conversation. It's a very delicate conversation, especially when the patient does not either have insight into their own memory loss, they are not aware of it, or I'm noticing it for the first time. Now, I'm able to with my own patients. I have rapport, I have trust, and we can talk about it, but it's still a delicate conversation. So what does the workup look like for someone who has cognitive decline sort of subjectively? Either I notice it or the patient notices it, a family member notices it. First thing is we need to have a brain MRI. So we do a brain MRI with a focus on the hippocampi. The hippocampi are the little parts of your brain that in part control memory. And so we'll order a brain MRI with and without contrast with focus on the hippocampi. And that's an important thing to note. Sometimes patients will get a brain MRI without a neuroquant analysis. Neuroquant is a way of quantifying how big the hippocampi are. A brain MRI, just a contrast-enhanced MRI that doesn't focus on the hippocampi is okay. It's a good test. It's just that it's better if you can do an MRI with and without contrast, with attention to the hippocampi, and with a neuroquant analysis. So primary care doctors need to know to order that in order to order the right test, and not all primary care doctors know that. The second thing, and by the way, a lot of people don't want to have an MRI when they experience cognitive loss because they're afraid of the findings. They're afraid to see that they have atrophy of their brain, or afraid to see that their hippocampi are shrunken. I'm going to go back to the original point, which is that an MRI alone is not diagnostic for dementia. So you can have a normal MRI and you can have cognitive decline and or dementia. You can have an abnormal MRI. I have a patient who has a very abnormal MRI who I would guess, if I was just looking at her MRI, that she would have significant memory loss, and she does not. So again, this is all contextual. First step, brain MRI with attention to the hippocampi and a neuroquant analysis. Number two is assessing their vascular risk factors. So as I talked about in the beginning, there are two basic buckets of dementia. One is a vascular dementia, and one is the neurodegenerative types of dementia. If we think about dementia as those two kind of main buckets, the next step is to assess their vascular health. So when I'm assessing someone's vascular health, I'm assessing the things that you probably know about already that we assess when we're looking at cardiovascular health. So when we're assessing someone for cardiovascular risk, for heart attack risk, whether you know it or not, we're already assessing you also at the same time assessing you for cerebrovascular risk. So the cardiovascular risk and the cerebrovascular risk are similar. What do I mean by cerebrovascular risk? I'm talking about the blood vessels that supply blood to the brain. Those are what we're assessing. And the blood vessels that supply blood to the brain talk to and are in connection with, direct connection with, the blood vessels that supply blood to the heart. So people are very well versed in general in the public square about heart attack risk and stroke risk. What they don't always understand is that the same risk factors for heart attack and stroke are the risk factors for vascular dementia. Why is that? Because what we're talking about is the blood vessels, the arteries that are the highways that bring blood to whatever organ we're talking about. And in this case, we're talking about the brain. Cerebrovascular health is what we're talking about. So when I'm assessing someone's risk for vascular dementia, I'm assessing their risk factors for vascular disease in general, whether it's the heart, whether it's the kidneys or the brain. Number one, cigarette smoking. Cigarette smoking is one of the biggest risk factors for atherosclerosis, therefore heart attack, therefore stroke, therefore vascular dementia. So cigarette smoking, I talked about this last week. I think it was last week or the week before. What do cigarettes do? It actually makes the surface of the blood vessel more rough and inflammatory and more readily able to let little cholesterol particles burrow under the lining of the blood vessel that then causes accumulation of cholesterol and plaque, which then over time can cause the lack of adequate blood flow to whatever organ we're talking about, whether it's the brain or the heart. So we're looking at cigarette smoking. We're looking at blood pressure. We're looking at cholesterol levels. We're looking at family history. We're looking at diabetes. And then we're also looking at the newer biomarkers, such as the lipoprotein A and the apoprotein B, which I talked about a couple weeks ago, as additional ways to help understand my patient or your own risk for vascular disease. So again, going back to what we were talking about, we're talking about the classic patient who comes in, who's concerned about his or her memory loss, who's actually has objectively and subjectively some memory loss in my office. Whether they notice it or not is another story. The first step is the brain MRI. The second step is to assess their risk for vascular disease, which hopefully I've already done, because if they're my patient, we're already thinking about vascular disease. That's part of the job of being a primary care doctor, whether people know it or not. So we want to modify those risk factors. If you're a smoker, we want to quit smoking. If your blood pressure is high and uncontrolled, we want to get that under better control. If your cholesterol is high, we want to get that better under control. If you have diabetes, we want to get that under better control. And if you have elevated biomarkers like the lipoprotein A or the ApoB, then we want to be even more aggressive about risk factor reduction, because those are thought to be markers of an increased risk for vascular disease. So when we're talking about vascular disease, again, we're not just talking about protecting from heart attack and stroke. We're helping people protect themselves from the absence of adequate blood flow to the brain, which can cause dementia in that first kind of bucket, that vascular dementia. So the good news about, if you will, there's nothing good about the word dementia or having dementia, of course, but the good news about cognitive health and preventative health in the brain space is that those risk factors are modifiable. So again, what I said up front is true. We used to think that our brains were fully formed by our 20s, and now we know that they're plastic. They're much more plastic than we used to think. And the more we can invest in adjusting our lifestyle, adjusting our modifiable risk factors, the better we do, particularly when it comes to vascular dementia. So my patient in the office who's complaining of memory loss, or whose spouse is saying my wife is, forgetting where she's going when she's driving. She doesn't know where, has a number of complaints that are concerning for early dementia. We do the MRI. We do a full assessment of their vascular health. And then we do some imaging of, for example, the carotid arteries. The carotid arteries are these two main blood vessels that sit in our neck that are the main highways that bring blood northbound to the brain. So I'll often look at the carotid arteries. Sometimes I'll do an MRA. Like an MRI is of your head, your brain, and an MRA is an MR, a magnetic resonance image of the blood vessels. Why is it called an A? Because A is angio is blood vessel. So an MRA of the whole circulation in your brain can be very helpful. Sometimes we'll just do a carotid artery duplex, like a sonogram. Depends on the patient. But basically what you're trying to do is get an image of the brain material itself. This is my universal sign for brain. And an image of blood vessels. So what is the organ itself looking like, and what do the highways that bring blood to the brain look like also? And then once we get those images, once we get those blood tests for cholesterol and blood sugar, and once I've assessed someone's blood pressure, and we've talked about quitting smoking, then we can start to think about what we're dealing with. If someone, for example, has uncontrolled hypertension, they have diabetes, they were a cigarette smoker, and on MRI shows some atrophy of the brain, and they have obvious plaque in the arteries here, it's pretty clear this person has vascular type of cognitive decline. One of the ways we help define the type of dementia and make a diagnosis is also through neuropsych testing. So neuropsychiatric testing, if you think of it this way, neuropsych testing is kind of like the stress test for the heart. There are tests that look at the anatomy of our body parts, like brain MRIs, and there are tests that look at function. So the way we look at the function of the brain to find out just how well this person's brain is operating from a cognitive standpoint is to do neuropsychiatric testing. That can be done with a neurologist, and that involves a couple days of testing where you're doing puzzles and memory games, and for a lot of people it feels very, very demoralizing and dehumanizing because it reminds people a lot of being in like middle school or even like elementary school. So it can be a hard sell to get patients to do the neuropsych testing, but the neuropsych testing paired with blood work, paired with imaging of the blood vessels, paired with a brain MRI is really where we're going to get some traction on getting a diagnosis of what's going on with this person. Does that help? Let's talk about genetic testing for a minute. I'm going to do a little bit of a talk about genetic testing. And by the way, this is not going to be an exhaustive This is not going to be an exhaustive talk about genetic testing and dementia. But I'm going to just give you the high level. So patients ask me all the time, should I get the ApoE4 gene test? What is the ApoE4 gene test? The ApoE4 gene test is a blood test looking for the presence of a mutation in a gene called the ApoE4 gene. If you have mutations in this gene, you may be at higher risk for Alzheimer's. I'm going to say that again, and I'm going to say it slowly because I talk really fast. If you have a mutation in the ApoE4 gene, you may be at higher risk for Alzheimer's. If you have a negative ApoE4 gene, you may still develop dementia or Alzheimer's dementia. So I hope someday that we live in a world where genetics are more useful and where we have genetic tests we can pair with specific therapeutic recommendations to help people modify the risk if it is indeed increased based on a genetic test. The upshot here is I do not recommend ApoE4 gene testing in the vast majority of my patients, even in my patients who have two parents with Alzheimer's. Not in 2025, not yet. And I would love to be convinced otherwise, but I think it's coming. But it's important to understand that genes are not destiny. Your genetics do not predict the future. Your genetics are not your destiny. Genetics can set the table for certain diseases, but they don't make the meal. Does that make sense? Is that a good analogy? I just kind of made that up. Genetics will set the table, but they don't make the meal. In other words, you can have a gene positive for ApoE4 and never develop Alzheimer's. And what I feel, and what I think most doctors would agree, is that it is unethical to have a patient undergo a test that could change the way they conceptualize their entire life without any ability to offer them a specific intervention. In other words, until we have like a medication that's well tolerated, affordable, and highly effective at preventing Alzheimer's, I'm not interested in giving people a gene test that is positive and then they walk around worried that every time they lose their car keys, they have Alzheimer's. What I do recommend, though, when patients come in worried about their risk for dementia or if they actually have cognitive decline already, are the 6 pillars of health, cognitive health, that I'm going to talk about now. So let's go to those now. We talked about what is dementia. I guess we talked about what is dementia. Dementia is cognitive decline. We talked about the 2 kind of main categories of dementia that are common. The vascular type of dementia, meaning the absence of adequate blood flow to the brain itself. And then the other bucket of types of dementia, which is the neurodegenerative types of dementia, which is like an intrinsic brain problem itself. Alzheimer's, Parkinson's, frontotemporal dementia, and other kinds of dementia. So, and then we talked about the classic patients who come in, the worried middle-aged person who has a family member, and then the patient who is the person who has cognitive decline, objectively or subjectively, and that how do we work that up? And now what I want to talk about is what are the things in your power that you can do today to protect your brain today and to protect your brain in the future? Well, you're not going to be surprised that a lot of the things I talk about all the time help with brain health. And I just want to put a fine point on this because, again, we used to think that dementia was kind of like either you were going to get it or you weren't going to get it. And that, roll the dice and pray for the best. And if you had a family history, you were probably going to get it. When now we understand through incredible research advancements that we have a lot more control over our brains than we used to think. And why is this important? Because I think particularly in the world we live in right now, particularly when people are walking around so kind of disenfranchised from the medical system and often feeling disenfranchised from their own bodies, to have a sense of agency is ultimately what we want for whether it's the brain or for any organ, right? Like my job as a doctor isn't to lecture people and just give people a checklist of things to do. It's rather to empower them with information and ways in which they can have control over their own health, regardless of what their goals are. So it's uniquely satisfying as a physician to be able to say to patients who are worried about their risk for dementia or who have symptoms already to say, look, there are actual practical things you can do in your every single day life that you can do now to protect your brain. Number 1, physical exercise. Physical exercise has been shown again and again and again to help with cognitive health. And it's not just that exercise makes you feel good in the moment, right? I mean, maybe it doesn't make you feel good in the moment. Sometimes I feel really badly when I'm exercising. I feel exhausted. I'm like, I can't wait until this is over. But it's not just that exercise helps with that sort of satisfaction when you're done. It's more. It helps with actual improving blood flow to the brain. It helps with inflammation. And of course, exercise helps with reducing blood pressure and blood sugar, which also improve cognitive health. So what does this mean for you? Ideally, the CDC says exercise for 150 minutes a week. Patients ask me, does it have to be 150? The answer is no. I would say whatever amount of exercise you can do realistically and sustainably in your life is the amount of exercise you should do. A half an hour is better than none. Walking your dog around the block is better than 45 minutes of exercise every single day. People ask me all the time, what's the best kind of exercise to do, Dr. McBride? The answer is the exercise that is the best is the one that you'll do, the one that you'll stick with, the one that you find slightly enjoyable. If you find the exercising really enjoyable, you're lucky. But if you don't like exercise, find something that is the least punitive as possible. If you like walking, walk. If you like dancing, dance. If you like cycling, cycle. If you like swimming, swim. And if you don't like any of it, I would bring a friend. I would try to find some sort of realistic schedule that you can build into your regular life. One where you're going to set yourself up for success. So I never tell a patient who's not an exerciser to Get 150 minutes a week and start tomorrow. That is going to set you up for failure. If you're not exercising and you're like trying to start, set realistic small goals. Tell yourself you're going to exercise 2 days next week for 20 minutes, and then you'll succeed, most likely. And if you don't, that's okay too. Start slow, build it up. Strength training has been shown to improve cognitive health, short-term and long-term as well. Strength training separate from cardio. So ideally in that 150 minutes a week frame, you would get some sort of cardio and some sort of strength work. Strength work is good for myriad other health benefits, but particularly for brain health. So strength work meaning yoga or Pilates or lifting weights. Um, there are lots of videos online that people like these days. And if you particularly if you're an older patient or you have an elderly family member who you're trying to help them with their cognitive health, it's important to make sure that they're doing these exercises safely and supervised, um, because just because you can follow a video doesn't mean you're going to have the right form. Pillar number 1 is physical exercise. That's number 1. Number 2, in the spirit of talking about the 6 things you can do today to protect your current brain health and your future brain health. Number 2 is mental stimulation. So there's mental stimulation from watching like CNN and scrolling on Instagram. That's not the kind of mental stimulation I'm talking about. I'm talking about engaging your brain, using your brain in ways that it is not always used. So playing the piano, learning a new language, reading, um, engaging in conversation with people that you may not know very well, learning how to play bridge, learning how to play mahjong, learning some new skill, even learning how to cook. So, some activity where you are engaging your brain in new ways, where you have those little aha moments, and where you're feeling like you're back in school. So, Sudoku, Wordle, the New York Times crossword puzzle, or any crossword puzzle, games. There are so many apps on the phone that people can use to keep their mental stimulation going. Like the brain gym needs to be working all the time. Not every day. My dad is a great example of this. My dad does Duolingo, and he's learning French. He's relearning French. And I swear it has really, really helped him in terms of now he's like obsessed with it. He's so obsessed that all of us are kind of exhausted hearing him talk about it. But I'm very proud of him because he's really, really gotten good at French. And it's giving him a sense of satisfaction and joy. And it's also keeping his brain really active. My dad had a big job. He's been retired for many years, and this is a really important part of his life. And he goes biking, and I'm just so proud of him. So number 1 pillar of health that you can improve your cognitive health now and in the future is exercise. Number 2 is keeping your mind active. Number 3, sleep. Okay, sleep. Sleep is not something that is a luxury. I've written about this a lot. Sleep is a biological need. Sleep is when your metabolic waste from your brain gets cleaned up by little sanitation workers. They come into your brain and they clean up all the metabolic waste from the day to make you fresh for the next day. Now, when I tell patients they need to get 7 or 8 hours of sleep, they often laugh at me or they think that's impossible. And I understand that there's a difference between a doctor telling you to get 7 or 8 hours of sleep and actually getting it. Because getting sleep is hard. Getting sleep is difficult if you have insomnia, or if you have a noisy brain, or if you're taking medications that keep you awake, or if you're in pain, or if you have sleep apnea, or if you have a noisy bed partner. So these things are difficult to manage, but I would say to the extent you can center sleep and make it a job, like make it your job to protect 7 or 8 hours of sleep, that is really good for your brain now and in the future. What about sleep aids? So antihistamines like Benadryl, like that first generation antihistamine, benzodiazepines that people use for anxiety to go to sleep, Ambien, those are not great for our brain health, certainly if they're used in extended periods and for a long time. So I generally recommend safer sleep aids if you need them, because not getting sleep arguably is worse than sometimes the sleep aid that you're taking if you're taking a very safe sleep aid, like melatonin or magnesium or these CBD gummies. And I did a talk about sleep. I think it was last week. You can listen to that if you want to get more details about sleep and my thoughts about it. sleeping in a cool room, sleeping in a dark room, getting your cat out of your room. My cat was in my room 2 nights ago. I decided that instead of him knocking on my door, my bedroom door in the middle of the night, I would leave my bedroom door open. Thought that would be a good solution. Nope. He slept right next to me, and that was fine until he started nibbling on my fingers and nibbling on my ring. And it was adorable, but I did not sleep well. So cat is now in the basement. Pillar number 1, going back to the beginning of modifiable risk factors for your brain right now, physical movement. Number 2, mental stimulation. Number 3, quality sleep. Number 4, stress management. Aha, the good old stress management. Wouldn't it be easy if I just said, manage your stress, manage your stress? And patients said back to me, oh, I hadn't thought of that. Great, I'll do that. Managing stress is not easy in this day and age. Managing stress requires a lot of concerted effort. It requires intention. It requires, first of all, noticing that we're stressed, and then it requires actual work. I was talking to a patient the other day, and I said to her, I think meditation, like transcendental meditation or meditating with an app, is pretty much a necessity of modern life at this point, given all the stimulation to our brains that is the unhealthy kind of stimulation from social media, from news networks. Our 24-hour news cycles certainly tax our brains and can make us stressed, not to mention the economy, the political situation we're living through, social unrest, wars. There's a lot to be anxious about. There's a lot to be stressed about. We are living in an era where mental health is in crisis, where people are experiencing enormous amounts of despair, depression, anxiety, addiction are on the rise. And it doesn't take, you don't have to look too far to see someone in your life or maybe yourself who's struggling with their mental health. So managing stress is a tall order. It sounds like it's like a bullet point on a list of things to do for your brain, but it's a lot harder to manage than a lot of people think. The first step is noticing where your stress lives. Where does it park itself in your body? Is it emotional? Is it cognitive? Like, do you ruminate? Do you catastrophize? Do you do the what ifs as you're trying to go to sleep? Or does stress live in your chest or your abdomen, or does it live in your gut? I'm seeing so many patients in my office right now coming in for physical symptoms that stem from emotional distress. It reminds me a lot of the spring of 2020 when, COVID hit and we were all just undone and not knowing what to do. I'm seeing a lot of jaw tension. I'm seeing a lot of neck pain. I'm seeing a lot of back pain. I'm seeing a lot of IBS. And it's not that stress is the only factor at play, but stress is certainly something that does live in our bodies and it has to go somewhere, right? So the first step in managing stress is identifying that you have it. If you don't have stress, congratulations, and let me know, what you're smoking, what you're doing. If you do have stress, identify that you have it, identify where it comes from, identify where it lives in your body, how it manifests, and then ideally figure out what your coping kit is. Broaden out that coping kit. Just like in 2020 when COVID hit, people who were managing stress just fine needed to have a few more kind of items in their coping kit. Add a yoga class once a week. Download that meditation app that's you've been noodling on downloading. Get off your screens if you can before you go to bed. Now, screen time is not verboten, but certainly reading a book before bedtime can make people feel drowsy naturally and also calm, unless, of course, you're reading something like violent. Ask for help. Ask for a therapist recommendation from your primary care doctor. Walk with a friend. Download your thoughts. Journal. Those are the kinds of things that you might want to start thinking about if you're trying to manage your cognitive health now and protect your brain in the long term. There's no shortage of evidence to show that stress management and managing mental health is an excellent way, evidence-based way to protect your brain, your cognitive health, and your future mental health. Next is social connection. So our most recent former Surgeon General, Vivek Murthy, and I did a podcast on this. We talked about an episode, this was like in 2022, talking about the data on social isolation and how social isolation really has meaningful medical effects and cognitive effects. So particularly in the pandemic, I was so distressed and despairing over my older patients who are alone, who we are depriving them of social contact because of the pandemic and the virus, for obvious reasons in the beginning. But as you may know, maybe this is you yourself, or maybe you have a loved one like this, the pandemic really took a toll on patients from a cognitive standpoint simply because of the social isolation. Now, let's acknowledge that social isolation and downtime and introversion is sometimes that's okay. Like wanting to be by yourself is great. I love a Friday night on the sofa with my cat and no one bothering me. I do. But I think what I'm saying is that prolonged social isolation, and certainly if the isolation is not desired and people are wanting to be more connected, can drag on cognitive health. There's no shortage of evidence to show that social isolation and loneliness can affect many parts of our body, but definitely cognitive health. So I would definitely recommend if you're experiencing social isolation yourself, or if you have a loved one who's socially isolated, to find ways to connect, whether that's phone calls with loved ones or Zoom calls or, walks with a neighbor, sort of trying to help the person connect with people in person, ideally. That social stimulation, that mental stimulation is really good for their brains. Um, the last pillar, the sixth pillar, is nutrition. So, what are brain healthy foods? People ask me this all the time. And there's no kind of like single list of brain healthy foods. What I often tell people is the antioxidant foods are great, the anti inflammatory foods, like for brain health, like blueberries, nuts, almonds, walnuts, for example, avocado, salmon. So things that are high in omega-3 fatty acids, things that have antioxidants. Antioxidants are thought to be sort of clearing up inflammation in the body. But in general, I'd say that the basic tenets of healthy eating for any disease prevention, like diabetes, is the same set of tenets I'd recommend for brain health. So prioritizing whole grains, prioritizing lean protein, prioritizing fiber, and prioritizing healthy fats. That's the name of the game. So the other thing that's important for our brain health that doesn't often get talked about is not just the content of what you eat, but the cadence of how you're eating. If you are someone who goes from like coffee in the morning to not much food during the day, and then you eat most of your calories in the evening, that's not great for your brain. Your brain is going hungry for most of the day. So try to make sure that you're eating on a regular cadence, that you're listening to your bodily cues. Hunger is a normal sensation. Satiety is a normal sensation. Satiety, the feeling of fullness after you've eaten, is good for our mental health, to feel full, feel calm, and that's good for our brain too. So it's not just what you eat, it's how you eat. But again, lots of fruits and vegetables, lots of fiber, lots of lean protein. That is good for brains. Alcohol is not good for brains. So alcohol is a neurotoxin. I've talked about alcohol so much in my Substack because it's relevant and because we're learning more and more about the negative effects of alcohol on basically every organ system in the body. And because it's a common, socially acceptable, legal way for people to socialize and have fun. I love alcohol myself, and I know it's not great for me. So when you think about how to improve your nutrition to improve your current brain health and your future brain health, really think about limiting alcohol. There's so many ways to enjoy non-alcoholic drinks these days. There are some really great non-alcoholic beers that I happen to love. I like the Athletic brand. I love kombucha, and I love a glass of wine every now and then. My 23-year-old son and I went out for tacos the other night, and I had a glass of rosé, and it was delightful. And I felt a little sleepy the next day. It was worth it. But the point is that alcohol is not good for our brains. There are lots of medications that are not great for our brains. So when you go to the doctor and you're talking about these 6 pillars, make sure that you're not just talking about food inputs and nutritional inputs when you think about cognitive health and protecting yours. Talk about the medicines and the vitamins and the supplements you're taking, because everything we put in our body, all the inputs, counts in my world as inputs and relevant to your whole health. If people want to hear about hormone replacement therapy, I'll stay on for another 5 minutes to talk about HRT and brain health. There's a lot of hormone replacement therapy is for some reason it's controversial again, but in a different way than it was in 2002 when the Women's Health Initiative came out. What we know now about hormone replacement therapy is that it is the best thing for bone health. Like that is shown. It's the best way to prevent osteoporosis, and the absence of estrogen in the body is the number one driver of osteoporosis. So it makes sense that giving someone back estrogen would help with osteoporosis. What we don't know, and we may never know, because doing these trials would take generations and would take it might actually be unethical to run. What we don't know for sure is whether or not estrogen protects people from dementia or Alzheimer's vascular dementia. If I were a betting woman, if I were someone who liked to play the slots, liked to play the horses, I would bet that estrogen protects against cognitive decline. For everyone? No. Always? No. Perfectly? No. But we have enough data to show that estrogen certainly can help protect against hot flashes, and hot flashes are thought to be associated with future dementia. We also have a lot of data to show that patients who take HRT sleep better. They have more cognitive clarity in when they're taking HRT. That it would be hard for me to imagine that we'll find out that HRT does more harm than good for dementia prevention. Now, it depends on when you start HRT. HRT, as you may or may not know, is the standard of care now for women to start it if they are in that 10-year window of their last menstrual cycle. So if a woman has been in menopause less than 10 years, then they should be on HRT unless there's a reason not to be. And that, in my opinion, is going to be shown over time. I can't even say my opinion because I have no idea, but I would be surprised if we don't learn over time that HRT is helpful with dementia prevention. Um, Maura, can you talk about arthritis, joint pain? Do you mean, and when is it too late to HRT? Is it contraindicated active protein C resistance? Um, Two good questions. So they're kind of they're so HRT. When is it too late? It's never too late. We say that the 10-year window is the best time to start it because that is the best time to start it. We have evidence to show that for most women, if you start HRT in the first 10 years of the woman's last menstrual period, they tend to do better. When it comes to bone health, certainly, and in terms of all-cause mortality. Um, when is it too late? It's never too late. You have to have a nuanced conversation with your doctor about it, um, because it's about risks and benefits and weighing the risks and the benefits. The reason why the Women's Health Initiative study was halted in 2002 was two things. One, there was a signal that showed a correlation, and it was messaged as causation between hormone therapy and breast cancer, when it turns out that HRT does not cause breast cancer. It was also halted early, or actually it was just found out of that study that HRT looked like it could increase the risk for cardiovascular disease. But looking back on that data and meta-analyses, we see that the reason that is the case is because HRT was started on older women in those trials. So those were women who already had those risk factors develop. So we can't say that HRT caused cardiovascular disease. We can just say that HRT was started in women who probably already had it already. So observational studies before the Women's Health Initiative showed, now these were observational studies, but showed that HRT did help prevent cardiovascular disease. I did a long conversation with Sharon Malone about this a couple weeks ago, if you want to pull that up. Active protein C resistance is not a contraindication. Remember that hormone replacement therapy is usually delivered transdermally, estrogen that is, which shouldn't increase your risk for clots. So the risk you want to undertake with HRT, which is not zero, and the risk you want to take with protein C resistance, that's entirely up to you. The question isn't should you take HRT or shouldn't you? It's what risks are you willing to tolerate and what are the risks of not taking HRT for you? So that was longer than I intended to, talking about HRT and cognitive health. But the upshot here is that HRT is the standard of care for women who are in the first 10 years of menopause. And it makes sense to me mechanistically and based on what I've seen and the research we have available to us that HRT probably helps with cognitive health. And I can't see evidence that it hurts it unless you start HRT in women who already have cardiovascular cerebrovascular disease. So is that helpful? I hope that makes sense. I hope that's helpful. I think the upshot here with cognitive health is what I said at the very beginning, which is that people often think that if they have dementia in their family, especially if they have Alzheimer's, that they think that the writing is on the wall and they don't have any control over their destiny when it comes to cognitive health. And we now know that people have a lot more control over their cognitive health than they think. And I would take those 6 pillars and tuck them away in your brain because you have room and employ them where you can. Again, I'll just review them: physical exercise, mental stimulation, quality sleep, stress management, social connection, and healthy nutrition. Those tenets matter meaningfully for your brain health. They also are good for your overall health. So, to the extent that we all feel out of control about everything all the time in the world we live in, take those to heart and bring those to your everyday life. Weave them in where you can. Don't be perfectionistic about it. Try to have realistic, sustainable goals for yourself and know that you have more agency over your health than you might think otherwise. I hope that's helpful, and I will see you guys next week. And thanks for joining me. Bye.